So good morning, everyone. Welcome to the Investment and Payment Workgroup meeting for December 2024. We're excited to have you all here. And I'll start again, my name is Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance for the Office of Healthcare Affordability. If you all wouldn't mind starting by just including your name and organization in the chat to get us started with introductions, that would be wonderful. So we are focusing today, walking through our agenda. We'll focus a bit on defining behavioral health spending. We'll review the workgroup feedback from November. And then we'll also spend a lot of time today thinking through measurement. So we'll start with a brief overview of our approach to defining behavioral health measurement, and then we'll review the feedback we heard. We'll talk about defining behavioral health measurement using claims, and then we'll wrap up with next steps and adjourn. So I think our next slide, just as a reminder, please introduce yourself in the chat. And when you are adding chats to our discussion, we would appreciate if you all could include your name and organization as well. And then I think the other note is, as always, we may not always get to every chat or all the discussion that happens in the chat, but we document it and we use it to inform our future workgroup meetings. And this is just a reminder of our investment and payment workgroup members. And we're hoping that one of our workgroup members who hasn't been able to join yet, Yagnesh Vadma from Magellan, will be able to join us later today. So if and when he joins, we will make sure to introduce him to you all. And I think, unless there are any questions in the chat, I will go ahead and turn it over to Debbie to walk us through defining behavioral health spending and our brief introduction there.
Thanks, Margareta. And good morning, everyone. I'm Debbie Lindis, manager of the Healthcare Delivery System Group at the Office of Healthcare Affordability. I use she, her pronouns. And in these next two slides, I'll start us off by reviewing our high-level approach to defining behavioral health spending as a reminder to frame our main discussion for today. So you've seen this slide before, showing the general equation that OHCA will use to measure behavioral health spending, which is the numerator here. OHCA's statute requires us to measure behavioral health spending as a percentage of total medical expenses, which is our denominator. Both the numerator and the denominator have claims and non-claims components because the data for measuring those two elements are different. And as you can see in the note here, our numerator will include patient out-of-pocket responsibility for behavioral health services obtained through their plan, essentially services for which a claim or encounter is generated. The denominator will include pharmacy spending, as well as that patient out-of-pocket responsibility for services obtained through the plan. And I'll note that we'll seek your input on whether or not to include pharmacy spending in the numerator. For today's main agenda item, we'll be discussing our approach to that claims-based spending that's highlighted in the red circle on the slide. So here I want to highlight OHCA's proposed approach to measurement and benchmarking of behavioral health spending, which differs from how we thought about those two parts of our mandate for primary care. OHCA will take a broad approach to measuring total behavioral health spending and proposes a more focused approach to setting a behavioral health investment benchmark. This distinction is illustrated in the graphic here with the lighter blue circle inside the darker blue circle, showing how the proposed benchmark data will be a subset of the data we use to measure overall behavioral health spending. Last month, we discussed a framework for our investment benchmark, the light blue circle, and today our discussion will center on defining behavioral health spending paid via claims for use in the measurement of total behavioral health spending, that darker blue circle. And before we dive into our main discussion, I'll quickly review the workgroup feedback we heard last month. As you'll see in the next couple of slides, we've incorporated your feedback as edits to the proposals we presented at our November meeting. So in response to workgroup feedback, we made several revisions that we've shown in red on the slide. For the first proposal, concerning what we believe increased behavioral health investment should achieve, we added high quality and culturally responsive to the characteristics of the care we'd like to see Californians receive. We moved in-network to the end of the sentence for clarity. And for the second proposal, about how the behavioral health benchmark should support this aim, we added "and" between outpatient and community-based to clarify that these are distinct. We also highlighted that excluding pharmaceutical spending is still under consideration for both the total spending definition and the benchmark. With workgroup feedback, we've revised the proposal for supplemental analyses beyond OHCA's formal measurement of behavioral health spending that could support monitoring whether the investment aim is achieved. These are analyses that would use data from the healthcare payments data program or other sources rather than adding to the data that payers are required to submit to OHCA. At last month's meeting, we added monitoring crisis service use as well as emergency department use. And we added behavioral health facilities explicitly as a type of provider whose numbers and distribution should be measured. We've highlighted average therapy sessions per member as still under consideration because of mixed feedback we received during and after the November workgroup meeting. And I want to emphasize that this list functions as a parking lot at the moment. Over time, OHCA will collaborate with stakeholders and consider other data sources to scope out the proposed analyses, determine if there's data currently available to support them, and then prioritize them based on feasibility, interest, and level of effort. So now Mary Jo Condon, Principal Consultant with Friedman Healthcare, and I will kick off our discussion on measuring behavioral health spending using claims. Of our 3 modules for behavioral health spending measurement, for today we'll focus on definitions to capture claims-based spending. We'll return at a later meeting to discuss measuring non-claim spending for behavioral health and also to refining the specifications for pulling out behavioral health in primary care as a module for separate analysis. That behavioral health in primary care module will include both claims and non-claims spending. And as a reminder, OHCA proposes a phased approach to defining and measuring behavioral health spending. Our initial measurement definition and data collection will focus on the commercial and Medicare Advantage markets to reflect OHCA's data collection approach. Next, we'll adapt that commercial market definition to the Medi-Cal market, possibly incorporating data sources specific to Medi-Cal and making refinements as necessary. And of course, we'll be iterating on the definitions over time as we learn from experience. And now I will turn it over to Mary Jo to walk through the rest of this section.
Excellent. Thanks so much, Debbie. All right, let me go to the next slide here. So the diagram on this slide shows how behavioral health spend is determined by decisions about the diagnosis, care setting, providers, services, and treatments to include in the definition. And we're going to begin discussing these aspects today. And just as sort of level set for today's discussion, we're going to focus on categories, not specific codes. Once we have a sense of the work group's input, we will develop and share a code set for your review. Speaking of, to reach our final destination of a set of codes to define behavioral healthcare in claims, we would propose using the specifications from the Milbank report, which has been circulated and happy to circulate again to the work group as a starting point. These detailed code sets were developed with input from an advisory group of state behavioral health leaders and subject matter experts. So the Milbank work gives us a useful head start on our work. Of course, as we gain input from the work group and other stakeholders, we'll incorporate those perspectives into OHCA's code set. I'll talk more about Milbank's approach on the next slide. To tailor the definition to California's needs, we will then internally review code sets from the Department of Managed Healthcare and Medi-Cal, and we'll review those for alignment with the Milbank definition and incorporate additions as appropriate. Finally, we will draft and circulate a code set to members of the work group for their review and feedback. As a reminder, our discussion today will focus at the category level, so not on specific codes, but this would be sort of the first step in developing that code set. All right, so here's a little bit more background on the Milbank approach. Milbank used HEDIS value sets and other state definitions as a starting point for developing its definition. The HEDIS value sets are complete sets of codes, procedure, revenue, place of service, diagnosis, and drug codes that are used to calculate results on HEDIS quality measures. These code sets or value sets are used nationally, and there's specific value sets for mental health and substance use disorders. The code sets are typically used by health plans for calculating and reporting quality measures, but the states found that they were a useful starting point to developing their own code sets. As those states moved forward, they took those sort of base code sets and augmented them based on stakeholder feedback, similar to the approach planned for California. Currently, Maine, Massachusetts, and Rhode Island have definitions for measuring behavioral health spending using claims data. After the Milbank group developed a draft definition, an advisory group then reviewed and modified it to develop that final definition or that final code set. All right, so I want to take a pause here and open this up to get some feedback from all of you on our approach. Any questions or comments? Yes, Beth. Go ahead, Beth.
Good morning. So I just want to, I know the law requires you to measure the subset of spending that is referred to as total health care expenditures and the behavioral health spend in that. But I just want to take us back to what I think we all have consensus on, which is there's a lot of behavioral health spending that is not included in total health care expenditures. And important stuff like whether it's out of pocket, out of network, out of planned spend by consumers who are unable to access care timely, or county mental health, or some other aspects of Medi-Cal spending. So I understand the task we're working through today, which is to figure this out for total healthcare, that subset of spending called total healthcare expenditures. I just want to remind us that it is, even though it's called THCE total, it is in fact a subset, and that's even more true on behavioral health than on physical health. So just as a framing matter as we get into this discussion.
Great.
Thank you.
Thanks, Beth. Dan.
Rachel, could you just jump back one slide? I want to make sure I'm clear on, so that second bucket there, review Department of Managed Healthcare code sets. We don't have or collect this information generally, so I just want to make sure I'm clear on what you're looking for from the DMHC on this.
Sure. So I believe that's really just sort of circling back and talking with you about the services that your plans tend to cover and make sure that those services are included on our list.
Okay, that's easy. Okay, thank you. Appreciate that.
No problem.
clarification.
Yeah,
Of course.
I would just add for all of us that it probably would be good to go back and look at the requirements in SB 855, which is the most recent big change on what's covered for behavioral health. Thanks.
Yeah, Beth, I think generally that's based on medical necessity. So
Well, yeah,
a very
of course,
broad
but
range of services.
yeah,
Okay.
but broad range of services, broad range of providers, and the most recent update to the law. So
Thank you, Beth. That's a great flag. All right. I don't see any other hands up, so I'm going to go ahead and go forward and dive into these circles here. So the first one that we're going to tackle is diagnosis. So today we will review how Milbank and other states approach each of the 4 measurement components that comprise behavioral health spend. As an FYI, we're going to pause for discussion after each component so that we can gain your input and reactions. As I mentioned, we're going to begin with diagnosis. And there's essentially 3 principles that the Milbank process arrived at regarding diagnosis for using diagnosis to measure or identify behavioral health spend. The first is to include a specific set of diagnosis codes to identify patient claims with a primary diagnosis of a behavioral health condition. The second is to use all diagnosis codes for mental health and substance use disorders consistently used in state definitions. So essentially to take a broad approach to what is included. And last, to assign diagnoses and associated spending to mental health and substance use disorder categories. The purpose of that last piece is to identify spending separately or be able to calculate spending separately for mental health spending and substance use disorder spending. All right. So these are examples of categories that Milbank uses in its measurement definition. As you'll note, categories include most behavioral health conditions. I want to emphasize it's not an exhaustive list, but aims to provide examples of the diagnosis categories typically included in state behavioral health definitions. I also want to note that the technical specifications for data submitters will include a detailed set of ICD-10 codes. And as I mentioned earlier, we would develop that code set incorporating your feedback and share it with you for your review prior to making recommendations to the board. These states currently measure behavioral health spending, and they agree on most areas of diagnosis codes. However, there's a couple, 3 actually, categories that are used by some states but not by others. While the Milbank approach includes all the categories listed on this slide, states measuring behavioral health spend take different approaches to including these categories. So in determining whether to include 1, 2, all, or none of these categories, there's a few issues to consider. For dementia, some treatment is behavioral, while other treatment is medical. Including dementia enables accounting for behavioral health services by providers that treat the condition. Rhode Island and Massachusetts include dementia, Maine does not. For autism and other developmental disorders, unlike dementia, treatment is largely behavioral. Including developmental disorders in the definition would promote increased investment, which in theory leads to improved access. Massachusetts includes this category in its measurement of behavioral health spending. Maine and Rhode Island do not. The third diagnosis category on which states diverge is adverse effects of poisoning and self-harm. Some states choose to include
We lost you if you can hear us.
Yeah, but that
Yeah,
might
Mary
just
Jo,
be
I think
me.
We lost you.
I'm sorry, can you? Oh no, you can't hear me? Oh.
I think we lost you right at the beginning of adverse effects.
Mary Jo, I think you're all set now.
Can you hear me now?
Yes.
Yep.
Yes.
I'm so
We
sorry
can.
about that. My apologies. And yes, Parnika, I will come right back to that question. Let me go back just a little bit related to adverse effects, and then we can, oops, but not to a different slide. So the adverse effects of poisoning and self-harm, essentially some states include this definition in their definition, others do not. Those who choose to tend to do so because they're, it's the immediate effects of self-harm and poisoning are directly related to a behavioral health event. Are most often treated with services predominantly medical. Maine and Rhode Island do include in their definitions, while Massachusetts does not. All right, I'm going to go one more slide, and then we'll circle back to Parnika's question in the chat as well. So now we will open up for discussion on the following questions. Feel free to respond to one or two or all of the questions. The first is regarding the diagnosis categories with differing state approaches. Which should OHCA include or exclude? Dementia, autism and other developmental disorders, adverse effects of poisoning and self-harm. Are there other categories of diagnoses that should be included or excluded that you did not see on the list? And should the definition only count spending where a behavioral health condition is the primary diagnosis? And I just want to flag that we anticipate that that last question may require additional discussion during future meetings, but wanted to get everyone beginning to think about it. So I saw Nicole, I believe your hand was up. Yes, go ahead, Nicole.
I put it up and then I took it down really fast, but yeah, thank you. And thanks, Mary Jo, for taking us through this to set up the conversation. A comment on the first bullet. I feel pretty strongly that autism and that subsection of developmental disorders, or that full category, need to be included. I think that's it's also been reflected not too long ago in requirements for coverage and that in the States. So I feel like that's something we need to be measuring however we can and reinforcing however we can. I think with dementia, I think there was another one on the list that was physiological. It was either behavior or something. So anything that's overlapping with kind of post-cerebral vascular incident, I think we could talk on and on about any and all of those. And I'm not sure where we draw, unless I'm concerned that if in the primary diagnosis space, it's neurological in that way, and I apologize to the physicians on the call if I'm using the wrong terms, that we're going to be looking at kind of inflated spending, not inflated nefariously per se, but just it's going to be more expensive. Those, all of that care that goes into diagnostic and treatment. But if the primary code, right, says dementia, that's seems like it's going to be a lot more expensive and maybe not quite getting us to the mental health components of it. So same for adverse effects of poisoning, although I agree about however we can track the impact of self-harm. Oftentimes that's medical and emergency, and again, not something I think aside from occurrence and prevalence, I'm not sure we want to track spending on that. That's something, if anything, we want that to be lower. So I don't know, it seems like it goes against kind of what we're trying to do. I'll stop there. Thank you.
Thank you, Nicole. And I think that is a great segue into Parnika's question in the chat. So I'll answer that one and then go to Beth, if that's okay with you, Beth. The question here, can you clarify what you mean by medical treatment costs? Are you referring to pharmacological treatment? And not necessarily. So if you think of an individual with dementia, that individual may need hospital care, for example, for a UTI or a lack of nutrition, or a wide variety of reasons that are sort of tangentially related to the fact that the individual has dementia, but the services themselves are not behavioral in nature, and so would sort of clarify it in that way, and welcome to take additional questions or comments or other thoughts on that. Beth.
Yeah, 3 different comments or questions. Autism is, after many years of struggle, a covered benefit in California, and there's separate law on that. So I think, again, for commercial coverage, I think, again, I would distinguish autism from the broad category of other developmental disorders, which tend not to be covered benefits. And so I think there's a further conversation on that, which I have to say, when I originally looked at these slides, I didn't anticipate. But in hearing the discussion, I think we would want to look at what's a covered benefit currently and what's not. With respect to dementia, where, thank goodness, I have no clinical expertise or personal experience, I would just note that to the extent that we're focusing on the commercial population rather than the Medicare population, there may be some distinction in terms of age that just seems worth considering. Obviously, there are lots of people who have some degree of dementia, and that affects their physical health. But so I think that would bear further discussion. On the adverse effects of poisoning or other kinds of self-harm, obviously a classic symptom of a behavioral health crisis. And I agree with Nicole, something that if all this works the way we all hope it will, eventually people will get care rather than getting to the crisis point. But we wondered whether you coded separately for that, or coded for the self-harm piece as opposed to the care in the emergency room versus the treatment afterwards. So those are, I'm sure other people have struggled with these questions, so I'm just going to ask it as a question. So thank you.
Sure. Thank you so much, Beth. A couple of thoughts on that. One is I would note that the initial focus would be on commercial and Medicare Advantage. So to the extent that adjusts or refines your thinking on the inclusion of dementia, just wanted to make that clarification.
Yeah, but I mean, if somebody has early onset Alzheimer's in their 50s, they're a really sick puppy, to use a technical term. And as opposed to mild dementia in their 80s or 90s, which is, so I just think there needs to be some further. We are often separating THCE into market segments, and it may well be appropriate here as well.
Thanks, Beth. I think your other question there was regarding the use of the self-harm codes. Welcome others to weigh in based on their experiences, but reading the codes, my understanding is the purpose of those codes is to capture that sort of immediate treatment following an episode of self-harm. So, for example, the emergency department visit following an episode of poisoning, etc. Parnika. Parnika, I'm unable to hear you, but considering my past history on this call, that may be me.
I can't hear her either.
Okay. Parnika, I may go to Kevin Grumbach, and then we'll circle back to you. All right, great. Kevin. Oh, I'm sorry,
Yeah,
Carrie, you were next.
Yeah.
I apologize.
Hi
Go
there.
ahead, Carrie.
Yeah, the one, I think dementia, I personally would tend not to include. I mean, these are all judgment calls, but, it's got behavioral issues. I think it tends to be managed very separately from other mental health, behavioral health conditions. It's usually in the context of a lot of other sort of non-mental health issues going on with aging and things like that. So, yeah, that one I would personally not include in the behavioral health category for these purposes.
Thank you. Carrie.
I think I have a sort of more of a process comment, which is, these are all very important and worth considering. I think, as you explained, as you provide a little bit more background on the poisoning self-harm, perhaps that's not as, evident as something to be counted. But I think for dementia and autism, I would find it helpful to think about or look at use cases, like what exactly are we talking about? Because, it may be that, someone with dementia is, purely just getting medical evaluation. It may be that they need other, anti-anxiety or other medication or other treatment. I'm not an expert in this area either, but just saying, it could be, I think, helpful or useful for, I imagine, for this group to sort of talk about, what are the use cases of where we might see this from a spending perspective, if that's helpful.
Very helpful, Carrie. And that hopefully will be fleshed out a little bit as we talk about the services. Kirsten.
I'm wondering if you could repeat super quickly which states included or didn't include these 3 items.
Sure, absolutely. So let me go back to that slide for a second, for just a moment here. So for dementia, Rhode Island and Massachusetts include dementia. Maine does not. For autism and other developmental disorders, Massachusetts is the only one of the 3 states that includes. Maine and Rhode Island do not. And then for the third category, adverse effects of poisoning and self-harm, Maine and Rhode Island include. Massachusetts does not.
Gotcha. That's helpful. And I guess it would be helpful to me to know more about their rationale for including it or not. And a hypothesis that I would have, but I don't know actually how those states are structured, would be that perhaps the way that their governmental programs, whether it's oversight or delivery, look different from one another and perhaps look different from California. So my initial reaction, just personally, not necessarily on behalf of Hospital Association, but having worked in the behavioral health space for a long time, would be that I tend to feel that in California, dementia and autism and other developmental disorders don't really fit with the way that California conceives of behavioral health systems, behavioral health spending, and a strong emphasis on really mental illnesses and substance use disorders, which is not to say, of course, that those other categories are not completely worthy of expenditure or growth in expenditure. But I'm just curious to know more before deciding what my recommendation would be on whether, I think in some states, autism and other developmental disorders and even aging related health conditions are, there is a state agency that oversees the delivery of all of that care, and it's not as siloed as it might be in California. So I do think that's an important consideration, commercial insurance aside, because I believe that, I'm thinking of it as siloed because of the governmental programs that tend to focus on those issues and areas, and even strategic plans, right? California has big strategic plans for behavioral health that don't talk at all really about dementia specifically, or autism specifically. Those tend to be pretty siloed in our state from the standpoint of the term behavioral health.
Thanks, Kirsten. I can provide a little bit of color on two of the states, so Rhode Island and Massachusetts. I am not as familiar with Maine's process, but can follow up with the group on that one. So in Massachusetts, the decisions around these three specific categories, particularly dementia and autism, were based on stakeholder feedback. So stakeholders shared with CHIA, the Center for Health Information and Analysis, that it was important to them that Massachusetts include dementia and autism in its definition. And that's really where that came from. In Rhode Island, the definition was developed by the Office of the Health Insurance Commissioner, which regulates commercial coverage. And the definition was developed in most close partnership with other commercial payers. So the decisions in that state, I think, are probably most reflective of a commercial payer perspective. Does that help?
It does. I'm curious to hear what other people's perspectives are on it. And again, just a disclaimer, by saying I'm not sure I support having them included does not mean in any way that I don't think those are important conditions worthy of expenditure and investment. And of course would acknowledge they both include behavioral components, behaviors, which I think in terms of California's concept of behavioral health is a little bit distinct.
Sure, thank you. Catherine.
Thanks. I really defer to others here on two fronts. One is the clinical, and I see some really interesting comments in the chat, and also on the coding. I think, and others have said this, and I'll just repeat, that the issue here is both kind of almost philosophical about what we think is in, and then I also want to pay attention though to being very, very practical about where we do and don't have data. So just calling out Monica's comment in the chat about where we have good, where the coding allows us to really track actual behavioral spend and where it doesn't. And so again, neither of those are my expertise. I do in principle like the inclusion and support the inclusion of all of these categories. I feel most strongly about autism. And just on to Kirsten's last point, I hear that about sort of how we categorize things in California, particularly in our public systems, but I think we all agree that that siloing has not served us well. So I wouldn't want to put too much weight on a narrow definition of just services specific to mental illness and substance use disorder, given that we are starting with commercial and Medicare Advantage, and that we do have, we do have requirements in those systems that include, for instance, autism, and we know also that we haven't been successful really in increasing investment there in the way we think we need to. So would want to keep that one in for sure, and want to be practical about where we have good data across all three of them. Thanks.
Thank you, Catherine. And Beth.
Yeah, just to add one final piece on Kirsten's and Catherine's very wise observations about siloing in California and the ill effects of it. Autism is treated differently than other developmental disorders in our commercial and I think also our Medi-Cal programs. We have talk about peculiarities of California. We have California Children's Services, which historically less kindly was called Crippled Children's Services. And thank goodness that name no longer is around, but it is it, along with the K-12 system, is a primary source of treatment for a variety of developmental disorders. And we have the Lanterman Act with the promise that those with developmental disorders will be able to live in the community. So those things are unique to California as best I've ever understood it, and just add another layer of complication on this discussion that we have not yet touched, but here we are.
Thank you, Beth. Stephanie.
Hi, good morning, everyone. Stephanie Berry with Anthem Elevance Health. I just wanted to point out a little bit about, the recent federal mental health parity rule that's been finalized and how that pertains to how we deal with paying for claims. So everything that we are supposed to do from a commercial perspective is to look at what the condition is in the DSM or ICD-10 to define the condition. So essentially, if there are conditions in the DSM, that essentially means that we need to use that for looking at what behavioral health is. So dementia actually is included in the DSM. Autism was unclear. I mean, California laws notwithstanding, autism was unclear before. It is not unclear now. It is absolutely included in what we have to cover. And that also includes the whole broad spectrum of what autism includes, which would be occupational therapy, speech therapy, PT, physical therapy. So it's, I know that some of those things obviously cross over into medical spend, but from the perspective of what the mental health parity rule requires, all of those are included in our spending. So I just wanted to probably bring up the fact that that additional layer of what the federal mental health parity rule does can actually increases almost what behavioral health is. So dementia is in for what commercial health payers have to pay.
Thank you, Stephanie. That's really helpful context. All right, Parnika.
Thank you. I appreciate the previous comment about parity that kind of ties into what I was also going to talk about. I think most of you might know that I'm a psychiatrist. I'm representing the California State Association of Psychiatrists, but I'm also additionally boarded in geriatric psychiatry. So this is my bread and butter. I work with two primary subtypes of patients on a day-to-day basis. One is older adults with very severe mental illnesses, as well as older adults with what we call as dementia colloquially, but in the DSM, it's documented as either minor neurocognitive disorder or what we used to call as MCI, and major neurocognitive disorder, which is what refers to dementia. And there is a difference, a very clear difference between what these two things are. One of the things that I hear from folks about concerns that dementia is a medical issue because there's a medical treatment. If you truly actually see anybody with dementia, and again, dementia means that there's a major neurocognitive disorder, most of them will have some kind of psychiatric symptom associated with it. Psychiatric symptoms or psychiatric illness is not independent of a neurological illness. We know as psychiatrists in our training that a lot of psychiatric illnesses happen due to impairment in neurotransmitter flows, due to structural changes in the brain sometimes, and dementia is not an outlier in that sense. It is one of the illnesses where there's an involvement of two different specialties, but it certainly doesn't mean that it excludes psychiatry. Psychiatry actually plays a very big role in people who develop dementia. Most people who develop dementia go from a minor to a less severe form, to a moderate form, to severe form, unless something else causes early death. And in almost everyone with moderate to severe dementia, there will be psychiatric symptoms. And a lot of them require both pharmacological as well as non-pharmacological methods. And those non-pharmacological methods are behavioral in nature. So as a geriatric psychiatrist, I can certainly say that dementia is not just a medical illness. It is very much a psychiatric illness as well. If it wasn't, we wouldn't spend half the time in our fellowship training to learn how to treat it. The other thing, when I think I heard some comments about increased medical expenditure or the other medical expenditures for people with dementia, most older adults or most adults who have severe mental illness also have a significant amount of medical burden. And the reason that happens is because they don't end up taking good care of their health. And we know that a lot of severe mental illnesses, unfortunately, are chronic in nature and can either run throughout the lifetime or whenever they start. We are not really able to help people get into full remission. In fact, only 30% of people with severe mental illnesses will go into remission. And this is including depression. Those with schizophrenia and bipolar disorder have these illnesses chronically. And most people with such illnesses will have medical health issues throughout their life, which get exacerbated as they age. And that itself will also include increased medical expenditure. So I think if we start to think of dementia or start to exclude dementia because it has increased medical expenditure, we'll have to start doing that for all other psychiatric illnesses, and that will be a violation of the national parity laws that are in place. So I would strongly recommend that dementia should be included. I also agree that autism should be included. I saw that in the table that autism should have is largely behavioral treatment. We also see a lot of, not a lot, but a significant portion of children, adolescents, and adults who suffer from autism also can have very severe self-harming behaviors or severe mood disorders, which do require pharmacological treatment. Sometimes, again, because of their chronic illness, they can have a significant medical burden as well. So for those two, I do strongly think that they should be included. And for adverse effects of poisoning or self-harm, I know we talk about immediate after the aftermath when they go to the emergency room, but especially when somebody does engage in self-harm, and I'm not sure if self-harm, because self-harm doesn't necessarily mean that a patient will be admitted to a medical floor. A lot of the time, they might not be sick enough to require medical treatment, and they actually require psychiatric treatment. And even if they do require medical treatment, a psychiatry team always gets involved. So there is a significant component of behavioral health spending in that sense as well, which depends on the extent of intentional self-harm / poisoning. So according to me, in my own day-to-day clinical experience, all of these three things have a significant amount of behavioral spending. And my concern would be that if we excluded it, we would be missing out on important expenditure that is getting otherwise missed or actually getting missed. And I know that in California, there has been this question of using neurocognitive disorders or dementia to whether that is a psychiatric issue or not. With all due respect, I think it just hasn't been looked at a nuanced way. And as psychiatrists, we have been trying for a very long time for the government and for the legislature to see that this is not just a medical or neurological problem. Just because it hasn't been acknowledged doesn't mean that it doesn't exist. So I would just say that we are looking at the future. To use the past to make these definitions and diagnoses, in my opinion, at least for these few things here, would be limited. Thank you.
Thank you so much. Monica.
Yes, I'll be brief. I think, really thoughtful comments from folks. I think looking at it like this is a little bit too of a broad brush, right? I think what we really need to understand is like what's place of service, what taxonomy are you talking about, what code set, so we'll be able to weigh in a little bit more. Like I think you'll get more nuanced conversation from us about, are we talking about including the Alzheimer's drugs, right? Like when you say dementia, it's like, what are we talking about? Alzheimer's drugs, or the admission where someone had a hip fracture, but it also said dementia, right? Like that would bring us a little bit more clarity. Sort of similarly for adverse events of poisoning harm, are we talking about encounter where someone had a liver transplant because of a Tylenol overdose, but this code is also on there, right? Like those type of flavors will give us a sense of like, no, like we're not really talking about that. That's not what we're trying to include. Or maybe the answer is yes. Or an outpatient encounter where someone has a diagnosis of mild cognitive impairment and depression and is on sort of psychotherapy for the depression. So I think looking at it just with these three bullets maybe is not as useful to you all as those specific, like what's the top of funnel? What are we really talking about that we've already removed from even being included in measurement? And then we can weigh in on, yes, this code, not that code. Yes, this med, not that med. Because again, like we're not probably going to make much forward progress just by looking at the bullets like this.
Okay, thank you, Monica. Janice.
Thank you. Janice Rocco with the California Medical Association. As has been said by others in somewhat different ways, in terms of the autism piece of this, it would seem that it would need to be counted given our state laws and given that we for years have used mental health parity law to ensure that there are not, for instance, visit limits. So if we're going to consider it mental health for those purposes, we need to be considering, we need to be including it in this calculation, in this tracking. And in terms of dementia, certainly what has been said before by those who have more clinical knowledge than I, when it comes to the behavioral health treatment of dementia, there are certainly many folks who have never had needed behavioral health treatment prior to getting dementia or needed the medications that they need for anxiety before they are diagnosed with dementia. So I think that the aspects of dementia that are related to behavioral health treatment should be included. Thank you.
Thank you, Janice. And Kirsten.
At risk of adding another issue for consideration, was kind of thinking through, oftentimes when we have these conversations about dementia and other disorders of aging, quote unquote, another another health condition that's often discussed as a quandary about who's responsible, where do we increase access to care, are people with traumatic brain injuries, which very similarly are accompanied by behavioral health conditions and behaviors. So wonder if there's any conversation in the Milbank or other reports we're looking at on what to include or not include that relate to treatment of people with a TBI.
Vinayak, I'm not remembering any conversation that we included with the Milbank report on that. Are you?
No, Mary Jo, that's right. We did not discuss this specifically, but we can take a look at the code set to confirm whether there's inclusion at the code level for some of them.
All right, we'll do, and we'll circle back with the work group on that. Thank you, Kirsten. All right, let's go ahead and we will move on. So this is sort of building off of Monica's point, which is to talk a little bit about the services and treatments that would be included. I do want to highlight here sort of a limitation of the data in a way as we think about the combination between diagnosis code and service code. So one of the things that we're always trying to balance is the burden on data submitters with the need to have the definitions that have sort of the level of nuance that we would ideally like to see in order to count kind of exactly what we want. And so in some cases, that's simple. So for example, we would not, likely or would not likely recommend inclusion of something like a liver transplant for the instance of self-harm. That was a great example. Thank you, Monica, for letting me steal it for a minute. But in some other cases, it's a little bit trickier, right? So hospital visits are just sort of coded as hospital visits and there's a diagnosis attached, but sort of knowing all of the context around that visit is not possible with the claim. So that sort of forces us sometimes to make broader, more sweeping decisions about what to include or exclude than we would ideally want to. So just want to sort of give us that context as we dive into this next section. So for the next measurement component, which is services and treatment, Milbank relies on a set of 4 principles. So first, that there is a specific set of procedure codes to determine behavioral health services. Next, that the codes include services that typically only Medicaid programs cover. So just to give some context there, typically, though not always, Medicaid programs cover a broader swath of behavioral health services than commercial programs. And so the Milbank definition suggests that those services should also be included and that the definition not be limited to services typically covered by a commercial plan. The third principle is that spending in each service category is divided into mental health and substance use disorder based on the primary diagnosis code. So this is sort of picking up on and similar to the point on the diagnosis to measure those two buckets separately. Millbank includes prescription drugs as behavioral health treatments, and it uses national drug code lists that are in place in Massachusetts and Rhode Island to support that measurement. All right, so similar to the example list of diagnosis categories that we reviewed earlier, here is a non-exhaustive list of examples of the services and treatment categories that are typically included in state behavioral health measurement definitions. You'll note that the list includes inpatient, outpatient, and community-based services. And so now sort of moving us to the discussion, the first question is whether or not OHCA should include a specific set of services and treatments to define behavioral health spending. So the counter to this, or the flip of this, would be to say, nope, anything that has a behavioral health diagnosis, we are going to count as behavioral health spending. We're not going to limit by the services that would be provided with that diagnosis. If yes, OHCA would anticipate taking a broad approach since the behavioral health diagnosis would be required. And we want to get your input on, do you agree with that? Do you agree with taking that broad approach? And then secondarily, are there any specific services or categories of service that you would want to recommend OHCA exclude from behavioral health measurement? So I will open us back up to discussion.
Mary Jo, just a quick question. I feel like, correct me if I'm wrong, maybe it was in different contexts, that in some ways we've had this conversation. Is that correct? I remember seeing a bulleted list of services with us being asked what's missing, and we threw all kinds of stuff at you guys.
Sure.
So help me understand the context for this question versus the conversation we had earlier.
Yep. So let me go back for a second, because I think this slide back here will help. So the list of services that you saw previously were really related to getting your input on what might be included in a benchmark, which is a subset of total behavioral health spending. The list of services provided here, this categories of diagnosis, oh, sorry, that was categories of diagnosis. Those categories slides look the same. The list of services provided here is, honestly, I'll tell you how this slide was developed. We took that other list and added additional categories of services specifically around inpatient. And so the question here is really related to what do we measure as behavioral health spending versus what might count or be included in a benchmark to support likely increased behavioral health spending. Carrie.
Hi. Yeah, I'm just gonna jump in with a one area that I don't see included, but that I just would love to put on the radar, which is Proposition 1 initially in California was passed to really fund preventative services, but through culturally and linguistically responsive ways. And so a lot of the types of interventions that California has really been able to pilot have really focused on community defined evidence practices that can include like traditional healing practices, things that, right, like California just got the waiver for providing those traditional native healing practices. there may be other support groups, other types of practices. And, I just would want to call attention to that. CPEN actually has a brief, which I'll put in the chat, that
Thank you.
talks about, the use of CDEPs, and how, critical they are to our diverse communities in California. And, these would love to see more spending, focused on these types of preventative, services that can really help to impact health.
Thank you, Carrie, and thanks for putting that in the chat. Yes, Kirsten.
So my recollection of some of the debate that I think the group had, maybe not debate, discussion, was about sort of the pros and cons of being inclusive, because we want to count all the things we're doing as to the extent we possibly can in California to address behavioral health needs. But I do recall that there was a little bit of conversation about things like pharmaceutical, things like inpatient and emergency department. Is this the conversation where we are now revisiting those areas of kind of what should we do about whether or not to include those? Because I tend to, and I'll just be reiterating what I said on prior calls, that even if an individual is not accessing care in what some of us might consider the ideal place, I still think it should count, because it's a really important intervention that at least they got treated. I think it would be odd in other health conditions for us to say, let's not count chemo, because we don't want people to get to that point. We want them to have not gotten that sick. So I feel like, again, from the hospital association perspective, emergency department visits can be a critical place that at least people are accessing care. Inpatient admissions, I think you've heard from clinical experts that are far beyond my expertise, who talked about the fact that we do have in mental health or drug and alcohol many chronic conditions that, to no fault of our lack of prevention services, some individuals will be more acutely ill over the span of their lifetime, will have acute episodes, and it's okay to access inpatient or residential treatment. So I think from our perspective, we would not want to exclude services that may not be considered the ideal location, but rather at least people are getting access, because we know how many people from other studies live with mental health and drug and alcohol conditions and get no access. So whether they're getting in the ED or they're getting it through peer provided or community defined practices that we might want for everyone, I believe they should all be included. I say everything but the kitchen sink personally. And I think we talked about for substance use disorders as well, that EDs and other locations that might not be where you might traditionally think a person ought to seek treatment has become, at least in our state, a really important point of access, particularly for opioid and other substance use disorders. We have a lot of emphasis on getting people into, MAT and other things in the ED, and would want to make sure we're capturing people getting access at any point in the continuum.
Thank you, Kirsten. Just to reiterate, so the focus of today's discussion is on what is included in measurement. And Kirsten, I believe your comments are referring both to measurement and what would be included in a benchmark. So, but at least if they're sort of picking up on our previous conversation, just want to emphasize that today really sort of focusing in on that broader measurement circle. Amy.
Hi, can you hear me okay? I'm traveling in the car.
Can hear you great.
Okay, great. As a family physician, I do echo the last two comments in that having a specific set, I think may be a bit short-sighted as we look at measurement and spending and look forward in value-based care and value-based payment as it relates to behavioral health. So, you know, I see this in my clinics of how preventive care and preventive behavioral health can really affect the outcome of a patient in their behavioral health care. So you know, my comments would be to be more expansive and inclusive in not having a specific.
Amy, you did just cut out for us. Oh, sorry. Go ahead.
Yeah. Yeah, I'm just in favor of being more expansive versus having a specific core set of.
All right. Thank you, Amy. You are cutting out for us, but I think we've captured that input that you would prefer something more expansive and perhaps not even have a specific code set. Parnika.
Thank you. Yes, I just wanted to echo the previous comment about the fact that the more expansive, the better. And I guess as a psychiatrist, I might be biased, but we also know that people with chronic health issues often do not achieve full remission from their medical illnesses when their mental health illnesses or behavioral health issues are not adequately addressed. And it's not just like any other kind of medical treatment. Mental health, behavioral health treatment is not a one size fits all, and different people require different treatments. And I believe we are very fortunate to be around a time when there's so much exciting research happening and more interventions are coming up for people who previously had to just live with mental health issues and not get much relief from it. I did also have an informational question. I know that this slide up here only has examples of categories of service, but I was wondering if ketamine treatment, especially esketamine, is listed here also because it has popped up as one of the most promising treatments specifically for people with severe suicidal ideation.
That's so true. And that's such an interesting area of emerging research. Sometimes the definitions are sort of delayed, compared to what the most recent research is. So let us take that back and see whether or not the code set includes that, and then can circle back to you with an answer for that. That is a really interesting area. Hector. Sure.
Hi, yes, this is Hector with NHelp. I'm a little bit torn by this question because I think it's important to be very broad on what we include here, and I think especially because, as others have discussed, our parity statute is very specific about the services that private plans have to cover. And when I say specific, I mean it's specific in the sense that it actually requires plans to cover all medically necessary services, right? So, and then there's a rule that goes in detail into all of those services, but it serves as examples, right? Because the statute requires plans to cover everything. But at the same time, first of all, I think if we don't use a set of specific services and treatments here, that would actually change my response or reaction to the first question of diagnosis, right? Because then we would be opening the door to non-behavioral health services for a diagnosis that may include other services as well, right? That are not specific to psychiatric or that include other services, right? So I think I think my preference would be to be broad with the diagnosis, and then here keep a set of services, but then have that list be very, very broad and actually go back to the SBA 55 rule, look at all of that list and make sure that we include everything. The same thing with Medi-Cal, right? Because we're going to be at some point measuring that too. I think it's important to look at what services are included in Medi-Cal or covered in medical, and make sure that we measured those as well. And then the other point that I was mentioned about having that specific list of categories of benefits is that I don't think we want to be that broader than the benchmark. It makes sense, of course, that the measurement is the set for measurements is broader than the benchmark, but I don't think we want to be that broad that then at the end of the day we're sort of implying that the investment needs to go down, right? Because we are all over counting on the behavior on the services for the measurements. So that's why I think it's obviously those services are going to be broader. That list of services is going to be broader for the measurements than the benchmark. But I don't think it should cover everything. I think we have to have a broad set of services, or a specific list of services. And I think this list that we have here captures most of it. But we have to double check that we include everything that's listed for that same reason, because private plans are supposed to cover everything that's Medicaid necessary.
Thank you, Hector. That's really helpful. And I appreciate how you sort of wove together the discussion that we were having on diagnosis with this discussion on services and treatments. And with that in mind, I'm actually wondering if I could ask folks to maybe just, give a thumbs up with the react button if they agree with sort of conceptually what Hector is suggesting here, which is that we would use a broader list of diagnoses codes, so perhaps include the 3 that we discussed earlier today, and then have also a broad set of services and treatments, but do limit to certain services and treatments in a way to kind of support that broader list of diagnosis codes, so that when, for example, there's a service for an individual with dementia that may be more medical in nature than behavioral, that would not be covered. So if you like that line of thinking, if that aligns with your thinking, if you could give me a thumbs up, that will help us understand if folks are in general agreement with that approach.
Could we get a couple additional examples? That might help me figure out.
Sure. So for example, let's say that there's an individual with a diagnosis of dementia, and that individual has a therapy session that would be covered. But if that individual was hospitalized for breaking their hip, but the dementia diagnosis happened to be put in the first spot, some of the hip surgery would not be covered.
Mary Jo, so would preventive services related to the behavioral health diagnosis be covered?
Yes.
Okay.
And when you say preventive services, Amy, can you share with me a couple of examples of what's in your mind when you say that?
Good. If I had a cup of coffee.
I understand.
I'm sorry, I'm going on fumes right now from a red eye.
I'm so sorry.
No, it's okay.
Flu shot in the primary care visit for someone that has dementia, does that count?
Yes, a primary care visit for somebody who had dementia would count as in this scenario.
Do things like initial screenings or assessments, how would we capture those sorts of things? So for example, an individual, so if you start with, if it has a diagnosis, then we look at what the intervention was and decide whether to count it. But in some cases, the intervention might be pre-diagnosis.
Yep.
So we want to do a little bit of both, where, they had a depression screening during the well mom visit. We're going to try to grab that, even though this was not a person with diagnosed depression.
Great call out, Kirsten. The Milbank specifications, technical specifications do account for that. And they have that list of screening codes. And they say, this is a different situation. These codes do not require a positive diagnosis, because we know that many people are screened and don't have a diagnosis, but it's still important that everyone be screened. All right, I did see several thumbs go up as I was asking whether or not folks had general agreement with that, and seeing more now. And so please continue to give us your input and feedback. I'm going to go ahead to our next category here, which is on care setting. So the next component of the definition is care setting. The Milbank approach is to use a list of CMS place of service codes and National Uniform Billing Committee codes, known as revenue codes, to define care settings. They then use care setting in combination with services to identify service categories and subcategories. And we will review examples of Milbank's subcategories in a moment. I want to note that the biggest reason to include these slides on care settings is not really to restrict by care settings, but rather to organize by care settings. So this will make more sense in just a minute, I promise. Here are some examples of care settings divided into outpatient and community-based and facility-based settings. Again, these are examples. It's not a complete or exhaustive list. Outpatient and community-based care settings include office, telehealth, home, and mobile units. And inpatient settings include general and specialty hospitals, nursing facilities, and others. Again, including care settings as a dimension of measurement facilitates a benchmark that could be focused on only certain care settings. And from a measurement perspective, as I mentioned, the purpose of including care setting is more to organize information or spending than to limit it. Including care settings also allows states to group care into categories and subcategories to support analyses. So for example, if you want to understand behavioral health spending in a psychiatric unit or other inpatient hospital settings. And we're going to talk through this in more detail on the next few slides, and then I will open up for discussion. So defining behavioral health at the code level allows OHCA to give clear instructions to data submitters about how to organize their claims data to measure behavioral health spending. It also allows for consistent measurement of over time. And defining behavioral health spending by these four components offers flexibility for analysis for important policy questions and public reporting. And so this slide aims to illustrate that flexibility. So first, over here in step 1, as we mentioned earlier, the code sets define what is included in behavioral health spend. And there's decisions that are made about the specific sets of code sets used for each component. Those decisions determine that are included in behavioral health spend. Care settings can then be grouped with services and treatments into subcategories. And we're going to look at some examples of those in the next couple of slides. And then the subcategories can be grouped into categories for more streamlined reporting. The availability of spending subcategories supports analyses of trends and shifts over time among the subcategories to help evaluate movement towards policy goals. Subcategories also, as I mentioned, can be grouped into those categories so that folks aren't looking at, 8 or 10 subcategories and sort of trying to make sense of them. These are some examples of subcategories included in the Milbank report. The Milbank report envisions that states would combine subcategories to develop service categories and benchmarks based on state priorities. As I mentioned, these are just examples, and these examples are facilitated by taking those care settings, so place of service codes and revenue codes, and combining them with services and treatments and diagnoses. The subcategories can then be rolled up into service categories. So for example, inpatient facility and inpatient professional could be rolled up into an inpatient category that could be used for public reporting. We've talked a little bit today about this relationship between the measurement and the benchmark. So returning now to that relationship, you see here data for measurement of overall behavioral health spending and data focused on setting a benchmark. The benchmark, again, represented by the inner circle, could focus on community-based and outpatient services, such as mobile services, outpatient facility, and professional care, including primary care and telehealth services. The service categories for the benchmark are a subset of those used for overall measurement. In addition to the benchmark categories, which we've highlighted in light blue, and again, these are all proposed and potential, nothing has been determined, total spend measurement would also include categories such as emergency department services, observation services, residential services, long-term care, and inpatient services. And so moving us now to discussion, I wanted to get your thoughts about grouping behavioral health spending into subcategories and categories. Do you see this as a useful approach to better understand how dollars are spent? And are there particular categories or subcategories that you would like to see to better understand spending in those areas? Kevin.
Yeah, I mean, this gets so complicated. Having done the primary care measurement and spending now, this is even more complex and tricky. I'm sitting here reflecting. I appreciate all the very perceptive comments people have made and in chat, and I'm just trying to step back a minute and think really what's the policy objective here. And I think, Mary Jo, that's some in that graphic of the circles within circles. It's, I'm coming back to something like a surgical procedure that may be for a behavioral health condition, or, whether it's gender affirming surgery or dementia, and somebody falls and breaks their hip. But from a healthcare system point of view right now, it's not that we have a problem in resources dedicated to hip replacements, right, for people who break hips. And I'd say even gender affirming care, right now, I think there's resources, in particularly in California, for surgical procedures and things like that. It's not hard to find surgeons, let's say, who are now participating in that. The biggest policy needs seem to me really dedicated behavioral health, professional services. I think that's where my sense is the biggest gap, and that's whether it's for young folks with autism or whether it's for even, let's say, behavioral agitation and paranoid thinking in a person with dementia, or just for, intensive therapy for somebody with major depression or psychosis treatment. So those are the things. So I'm trying to step back, because we start to get into, like, if all the care for somebody who has a diagnosis, a condition that has a behavioral health, diagnosis, it's a lot of spending that's probably not the priority for what we really want to get the state to invest in a more intentional way. So I think so. Maybe I'm coming down to, maybe that's right, Mary Jo. We have those circles, is like we can count a whole lot of spending that is for related to behavioral health conditions, but I think we really want to be able to pull out the subset where I think we'd find that's where there's underinvestment of things that really need to be supported better.
Thank you, Kevin. And just sort of building on that point and kind of going back to this slide for a moment that you referenced, I think there's perhaps a couple of points there. One is that this benchmark could be a subset of measurement. And then also to Hector's point earlier, that under measurement even, you may want to have a set of services, albeit broad, but a set of services that are included as behavioral health. So that then if you do have some diagnoses included, as Parnika mentioned, many behavioral health diagnoses have medical components as well as behavioral components. You're able to include all of those diagnoses, but really focusing in on the behavioral health spend. We just have a moment left, so going to turn it back over to Margareta to close us out. We will cover the provider component during our next meeting.
Thanks, Mary Jo. I know this has been a really robust discussion today, and we will continue it next month in January. So thank you all for the great discussion today. I really appreciate it. Again, this is just our tentative timeline, and then for the work group meetings and our board and advisory committee meetings, and then for January, we again aim to focus our discussion on defining behavioral health spending measurement using claims. We may also begin to discuss our approach to non-claims behavioral health spending measurement, and potentially ambitious would be to discuss claims and non-claims behavioral health spending benchmark. So thank you all for the wonderful discussion today. I know there were some questions in the chat that we were not able to get to. And yes, to Stephanie's question in the chat just recently, the 2025 meetings will be held on the same cadence. So at 9 a.m. on Wednesdays, I think it's the third Wednesday of every month, and we will make sure you all have the Outlook meeting invites for the rest of the 2025 meetings. So thank you all for the wonderful discussion today. Please feel free, if you think of anything else that you wanted to contribute to the discussion, feel free to send me an email, and we'll take that into consideration as we're working towards building the materials for the January work group meeting. So thank you all, and we hope you have a happy holidays and a wonderful new year, and we will see you in January.